Let's Talk Health, sponsored by the Axis Health and Wellness Association. Had a great week for you this week. Great show. We've got Dr. Avery Buchholz with me today, and we're going to be talking neurosurgery. And Dr. Avery Buchholz is from the Orlando Health Neuroscience Institute right here in Orlando, Florida. Avery, thanks for coming on the show today.
Thanks, Dan.
Appreciate it.
Me.
You and I, just recently became acquainted as you just joined Orlando Health. Tell us a little bit about the Orlando Neuroscience Institute.
Yeah, it's a big dynamic group. In terms of neurosurgery groups and what we offer and what we have, we've got the full spectrum. So, we're, which is one of the things that attracted me to the group. We've got 14 surgeons. We cover everything in the realm and the spectrum of neurosurgery, all acuities of care. There's nothing that we don't do or aren't capable of taking care of, and we're a tertiary center for much of Florida, especially Central Florida. So it's a very exciting place to work and progressive in terms of the things we're doing and the types of surgeries we're doing.
Awesome. It's a brand new building, correct?
Brand new facility, a physical space. The group has been there a while. The practice has been there a while. We just have a new physical space. The actual Neuroscience Institute, which is a beautiful building. We have pain management in the building, neurology in the building. All of our neurosurgery clinics are in the building, so it's great.
Awesome.
Yeah.
Well, let's talk about you before we get into that too much. We dive into that, but basically, tell me a little bit about your reason for and where you went to school and your reason for becoming a nurse.
Yeah, my path's probably a little different than others. I went to the Citadel thinking I was going to be in the military, and that was kind of the plan, and really enjoyed college and did well and enjoyed the sciences and kind of gravitated towards medicine. And that one thing led to the next, and got in med school and back home to Wisconsin, which is where I grew up, and went to med school there, then back to residency in Charleston, South Carolina, MUSC. Originally wanted to do orthopedics, but really loved the spine. And so where I was training, neurosurgeons took care of most of the spine, and the volume of spine was much heavier than orthopedics, so that's kind of how I gravitated towards that. And then from there, from MUSC, I went and did a spine fellowship at UVA. I was on faculty at UVA for 5 or 6 years, and then ultimately took the job here in Orlando.
So when you guys do your fellowship, that's when you're specifically focusing on what that specialty is going to be, that neurosurgery specialty.
You do not have to do a fellowship. Lots of practicing neurosurgeons do not, and there's plenty of spine training in general neurosurgery that we get, and so you're more than capable of being a good spine surgeon outside of that. But my kind of niche is complex spine surgery, scoliosis, deformity, and so I did a year of training to kind of get a little more expertise in that field.
Gotcha.
Yeah.
So when you're doing, your residency, when you're doing all your surgery training, what's it like when you first start, when you have to do that first surgery? Everybody has a first time, right?
It's a lot. It's intense. I think my first surgeries were actually in general surgery, because we do an intern, your intern year is kind of split between different specialties. And so my first was in general surgery. And it's a cool experience, man. It's kind of why you do it. And when you get there, like, oh, this is great. It's super exciting. And so it was a great experience. But yeah, very exciting.
So that first neurosurgery experience on the spine.
Yeah.
Did you sleep much the night before?
Yeah, we don't sleep much at all.
Yeah.
So there wasn't a ton of sleep, but it becomes commonplace pretty quickly.
Is that sleep thing, is that natural, or is that just, do you have to learn that?
You learn it
in that world.
It's just kind of, it is what it is, man. It's like, there's no other way around it. And it's, we work long hours. I loved it. I wouldn't do it. I wouldn't do it over, but I wouldn't trade it for anything.
Gotcha.
But I loved it, and it's a lot of work, but at the end, it's worth it.
Yeah, gotcha.
Yeah.
So, how does a Wisconsin boy get to Orlando?
Yeah,
what made you come here?
Well, lots of reasons. My family does live in Tampa, so I'm not totally foreign to Orlando, or Florida. But my biggest reason was the group. We've got great partners, really exciting opportunity here at Orlando Health. It's very busy. The type of patients we see are very complex. There's the entire scope of practice here. Lots of trauma, lots of deformity. Anything you want to do, we can do it here. There's good partners in the community. It's a very wholesome community. And I think it's a great place to work.
So Orlando Health, the ER is
It's one of the
main
busiest.
the main
Yeah.
trauma facility here in Orlando.
Yeah,
correct.
one of the busiest in the country too.
And you guys see a lot
We
of
do.
that stuff, right?
Yeah, we do.
Now, I'm curious of all that trauma that comes in that you guys see, how much of that ends up actually becoming surgery? Like if you had to guess a percentage of it.
Yeah, I would say at least 30-40%.
Really?
Yeah.
That many?
And that's surgery with us. You know, I'd say most of it needs surgery with somebody, orthopedics, general surgery, somebody. I'd say probably 34% ends up getting a surgery with neurosurgery.
Wow. And do you guys get the helicopter, flies
We get it
a
all,
lot of
yeah.
people, and that
Yeah.
tends to usually lead to some sort of surgery. If you're in that helicopter, you're probably
Yeah,
looking
if someone's
at
coming
something.
here with that level of acuity, then usually they need something done.
Gotcha. Wow. So, speaking of surgery, I want to get into a little bit about, what you're seeing on an everyday basis, what some of the easier procedures are, what some of the more difficult procedures are. But, let's start with the cervical spine. As a chiropractor, obviously we get a lot of patients that come in with degenerative changes, disc herniations, extrusions, all these different issues. When a patient comes in, and we typically know we've been through a lot of different things with them, and we know that they're a surgical candidate, what makes you determine whether or not they're going to do like a disc replacement versus the anterior fusion, and tell us a little bit about that.
Yeah, so it used to be more age-based, in terms of how old the patient is, their range of motion in the neck. And I think that's still true. Although a lot more patients who are older, are kind of asking for that replacement versus a fusion. And I totally understand the reasons and why, and I think that's an appropriate decision for most people. In my hands, I think ACDF and arthroplasty are pretty interchangeable. I do think a patient with neck pain, mechanical pain and stability issues probably does better with a fusion than an arthroplasty. But otherwise, if it's radiculopathy or myelopathy, I think taking that disc out, pretty interchangeable. You could do an arthroplasty versus a fusion.
Is there something we need to look out for as far as an activity level? Like if the person is really active into sports, would you prefer to do the fusion versus arthroplasty, or does not
I'd
really matter?
probably, if someone is very active and wants to get back to being active quickly, I'd say arthroplasty will get them back there quicker. Yeah. And there's different arthroplasty devices. They're not all the same. Some are better than others, and it's a matter of, there's not a lot of data, but opinion. There are some that are better than others. Longevity, I think arthroplasties do well. We've got good data now out past 15 years, and people have done well, and I think it's becoming more common to use these implants.
So the stability is consistently there.
Yeah, it's there, and ultimately the failure of an arthroplasty is kind of a fusion. When there are failure instances where the disc something may happen mechanically to the disc, but in terms of an arthroplasty not working, the spine just kind of fuses in that area, and that's ultimately achieves the same goal as a fusion anyways.
Interesting. Yeah, I always kind of wonder that when I'm talking to patients about it. Of course, we work together, and a lot of times, I can get into this briefly, but patients have typically failed conservative because you're a conservative surgeon. You want people to try different things.
I want to be an absolute last resort.
Yeah.
I want people have done all the therapies they can do, possibly injections, you name it.
You get people in there that go, I want surgery, and you're like, whoa.
Yeah.
Does that happen a lot? Or do people ultimately look for the conservative direction?
There are people who come in thinking that's what they want. We try and kind of redirect them and steer them and provide some alternatives, but that does happen occasionally.
Yeah. Okay. So yeah, that's interesting to know about the cervical surgeries. The difference, because I was always under the influence that just that anterior fusion is just more stable for the patient. But it was interesting what you said about the neck pain deal. If they don't have as much neck pain or just radicular pain, that arthroplasty is the way to go.
Well, yeah, and it's a discussion. There's pros and cons to both, and I think for certain people, if they're active, they want to get back to sports or life things, do things quickly. I think arthroplasty can be a good option for them. I still like an ACDF. It's tried and true. It works great. People do well. It's one of my favorite surgeries.
Longevity is there.
It's going to do well.
What's the time frame difference of the surgery?
The surgeries take about the same.
Okay.
Recovery, I think, from arthroplasty, we let people get back to full activities a little quicker, just because we're not trying to wait for a fusion. But ultimately, with a 1 level, maybe 2 level fusion, it's pretty quick too. You know, a couple weeks, month or two.
Yeah, I was just
Yeah.
going to ask that next question.
Yeah.
Like, what are you looking at as far as when patients, trust in me and I've known them for a long time, I always tell them, I say, it's okay to go a little longer and let the body heal.
Right.
I mean, because
Yeah.
I know you guys are like, yeah, we can get you right back,
Yeah.
but I tend to
Yeah.
proceed on the side of caution.
Yeah, not a right or wrong answer. It's a little bit of patient preference, personal preference,
Yeah.
provider preference. But yeah, a couple months to kind of get back to doing most things. I'd say 3 to 6 months to do everything.
Okay.
But after 6 months, generally they can do whatever they want.
So, in your memory, what is one of the hardest cervical spine surgeries that you've ever had to do?
I would say when somebody has, and I'm sure you've seen them, when they have big anterior osteophytes, kind of OPLL, where that anterior longitudinal ligament or posterior longitudinal ligament calcifies, and if you need to go in there and kind of take that off and decompress that off the anterior cord, it's so painful. It's stuck on the dura. It's tedious. You're risking spinal cord injury. There's CSF leaks. That's the least favorite. But in reality, it's something that probably needs to be done.
Yeah.
It's just not that fun to do.
Gotcha. And length of time, what's the longest neck surgery you've ever had to do?
I'd say probably 3 hours or so. Nothing crazy.
Does that 3-hour period of time go by pretty
Flies
quick?
by quick, yeah.
Okay.
Yeah,
I
flies by
figured
quick.
so. Well, let's talk a little bit about lumbar spine now too. Obviously, more weight-bearing area, harder area sometimes to deal with, but discectomy versus fusion. Talk about that a little bit.
Yeah.
I mean, I know the general basis of it, but stability, instability, that type of
It
stuff.
really just depends. Yeah, it depends on where that disc herniation is. If it's something we can get out through a discectomy alone, that's the preference. Fusion again, last resort.
Yeah.
But sometimes people have real bad foraminal stenosis where that nerve's in the foramen and you have to take that whole joint off or decompress that nerve in the joint. They're probably gonna need a fusion for that. If they've had, a couple discectomies already and, one, sometimes 2 or 3, probably gonna want to do a fusion after that instead of continuing to do the discectomy alone.
Now, in the discectomy case, when you guys go in and you clean it up, so to
Yep.
say, how often, just a general percentage, how often does that re-herniate? Because obviously it's going to potentially make it weaker,
Yeah,
right? If
and
the
I would
body doesn't fully heal.
Depends how old the patient is. I would say 20% of the time. But again, if it's a 30-year-old, they've got a lot more life left where they have chances to re-herniate than someone who does in their 70s or 80s,
Yeah.
But I'd say about 20% of the chance it re-herniates.
And how many times do you go back in and clean out that disc again until you ultimately make the decision to do the fusion?
Again, depends on the patient and how bad their problem is. I try and give them a second go. But after a second, usually the third time would be a fusion.
Okay. Do you guys see a lot of like the synovial cysts that happen
Yep.
on the joints that impinge the nerve and just have to kind of clean that up?
So like to stick needles in those if we can and aspirate them out.
Okay.
If that doesn't work, again, a decompression is appropriate. That one is one that you can make an argument to do a fusion right away. But again, I think most people try and do a decompression at least first. But the synovial cyst will tend to come back.
Okay.
And depending on how much of that joint you take off, that cyst may come back and they have to get back in there.
Okay. Now with the lumbar fusions, are you doing mostly like just the hardware, the screws, the rods? I'm hearing more about these cages. I'm seeing the cages. Explain the difference between
Yeah,
those.
so historically or early on, fusions were just kind of putting screws in, pedicles above and below a disc space, laying down a bunch of bone graft. Cages have come along to kind of restore height. So, you see those collapsed discs when you're on the x-rays in clinic. We can open that space up. We've got different techniques to do that. We put a cage in to maintain that height. And so that keeps kind of like doing decompressions as you would, kind of maintains that decompressed spine and height restoration. So there's different ways to do that. You can come from the front, from the side, from the back. So goals, again, are height restoration and then provide a fusion surface. So that disc space, we take the disc out, and that's where we get most of our fusion is there. So those are kind of the reasons and advantages of why we would do that.
So you had talked about decompression, like decompression therapy, which we provide and a lot of chiropractors provide. Are you a fan of the spinal decompression
I
therapy?
am.
In a lot of
I
cases?
think it's ultimately the same thing we do. And if someone says, "Hey, I felt great after decompression," It doesn't last as long as I want. I'm more confident that they'll probably have a good result with surgery because we're ultimately trying to do the same thing, just more permanently.
Yeah.
So I think it's great. And again, all those options for treatments I think are helpful.
And as well as my next point is the barrier we're getting to with the insurance companies.
Yeah.
Because they are now no longer, I guess, taking your guys' word for it that a person may need surgery. Oh, no.
Yeah.
We're going through this or going through that, which is good in a way, but I know it's frustrating to you guys when you know, like, this is, or we even know sometimes it's like,
Right.
this is what needs to be done, and you still can't get it
Yeah,
approved.
it's frustrating. It's for all of us. We're all in the same boat and trying to get help for our patients. But it is frustrating. It's becoming more and more common, more difficult to do surgery of any sort.
Does it ever put the patient in a threatening situation whenever the insurance company is dictating what they can or can't do?
I would say it probably does at some point in time. Yes.
Yeah.
Usually, if I have a patient who's in that situation, I'll send them to the emergency department if they are having an emergency. But there are times when insurance will just drag their feet and delay things. The other problem is they'll oftentimes go off what a radiology report, which sometimes doesn't have everything we want on it. You may see the same thing, or you may pick up on things that weren't necessarily addressed or picked up on a read.
Okay.
So those are kind of the issues we're dealing with, and they'll certainly want patients to go through different conservative treatments before any surgery, which we agree. But there are times when a patient, has myelopathy, they're dropping things, their hands are weak, they need something done, and those are the cases that are dangerous, I think, to delay.
And then you typically got to get on a peer-to-peer and just say,
Yep.
look, this is what's happening. And are they usually always quick to say, okay,
Depends on the insurance company. Some of them are deny, make us go through all the hoops, but some are more reasonable than others.
okay.
Yeah.
I want to keep talking about procedures because you said you also had done a fellowship in scoliosis.
Yeah.
Correct? So I had a case the other day where a lady, she's in her 50s, and she had a scoliosis fusion. How difficult is it? I mean, I know most scoliosis surgeries are recommended when you're in your, adolescent, teenage years because it's just
Yeah.
easier to fix at that point in time. How difficult is it to work and do a scoliosis fusion on a patient that's older?
It's harder. It's much harder than when someone's, in their teens. But I would say it's probably one of the more rewarding surgeries that we can offer somebody. In terms of quality of outcome and health improvement, it's equivalent with like a total knee or total hip. Patients, when they truly have sagittal imbalance or global imbalance, they do great. And so, historically, when neurosurgeons looked at the spine, we look at a small window of the lumbar spine on an MRI or a myelogram, and we'd look and make sure nerves are decompressed. And as long as things were decompressed, we'd say, well, I don't think there's anything we can do to help you. But we've kind of since learned about global balance and when, looking at the whole spine and how it's aligned, and there are patients who you see also who kind of walk all hunched over like this and they live that way, horribly debilitating pain, and so the goal for some of these surgeries is to get a patient in proper alignment and lock them in that position, and the downside is they lose range of motion, but for someone who's debilitated by their pain, they will take that 9 times out of 10, and people who have that condition do great. And I think it's one of the more rewarding surgeries we have.
How often do you do scoliosis surgeries on adults?
Most of the ones I do are adults. So
Okay.
adult degenerative scoliosis. So a lot of times people aren't always born with scoliosis. As the spine wears out, just like the foundation of a house, if it wears out unevenly, that spine can tilt and different pressure in different places. I'm sure you see it all
We
the
see
time.
that all the time.
Yeah.
So
And so again, that's a very large surgery. I see a lot of those patients. We only operate on probably 10%, 20% at most. Most people can live that way through the help of chiropractors, therapy, core strengthening, different things like that.
yeah, agreed. But that's interesting because I saw her 2 weeks ago and I'm like, oh, I got to ask him about
Yeah.
that. So
Yeah.
that is very interesting because it just seems like that was never happening back, when I first started,
Right.
but now it's
Yeah.
definitely happening more.
Yeah.
I'm sure technology, I mean, what's been different about technology, these advances in technology for you guys, for the surgeons?
Yeah, I mean, there's lots. Our techniques have gotten a lot better. The ability to do the same surgery in a shorter time has gotten better. There are robotics in spine surgery. It's still limited. basically right now the robot is an assist device to help us place pedicle screws, which I think is great technology, and we use it. I use it. I love it.
What is the advantage of using that robot for the pedicle screws, like for the patient?
For the patient, depending on how you do it, it can be smaller incisions. It can be less invasive. It can decrease time. For patients who have kind of a more complex spine, it can aid us in terms of knowing where to place that screw safer.
Mm-hmm.
And there are reasons to do it. There are patient-specific rods, patient-specific cages. There's kind of AI is creeping into spine as it is everywhere. So there are things we can do that are more data-driven.
Gotcha.
Yeah.
That's interesting. What about, I mean, I know you guys work in a 14 doctor group, and you guys all have different specialties. What are you seeing as far as, or what are your doctors seeing as far as these traumatic brain injuries that we're hearing about now in a lot of these auto accident cases? Not just auto accidents, but a lot of them are happening in the auto cases.
We see a lot of them because of the trauma here at Orlando Health. And so acutely, a lot of these people have bleeds. There are times when they need surgery, but most of these people don't need any kind of intervention acutely, but they're going to have traumatic brain injury.
What is the treatment that you guys have if it's a non-surgical case for the traumatic brain injury? What do you typically recommend for them?
Right now, kind of rest. There are some cognitive rehab things available. There's not great data that shows one is superior, that they're super helpful, but I think there is advantages to doing them.
Yeah.
But rest is the biggest one. Just like an athlete, and they take the time off of playing football or whatever their sport may be, cognitive rest is important.
Isn't it interesting how as time goes on, it's like the word rest for people is harder and harder for anybody to do.
Yeah.
Everybody wants it done now. They want to get back tomorrow.
Yeah.
When you used to get hurt when, 30, 40 years ago, the doctors were just like, just go home for 2 weeks, just lie flat, do nothing. And people were okay with that answer. You know what I mean? But now it's like, no, absolutely not.
Yeah.
I can't. Well, I'm going to go see this guy, or I'm going to go see this guy. He'll have
now everyone wants a quick fix, and it's kind of the way we are with
society. The way it's going, man.
The way it is.
See it more and more.
Yeah.
So like we talked about kind of the complications and that type of thing, but for a patient that is a surgical candidate, what other contraindications are you looking at that might not allow them to do the surgery?
It depends what the surgery is. For some surgeries, if they truly have spine compression myelopathy, they just need, usually we can get them done without much in the complication or concerns. But there are patients who may be too old. Osteoporosis is a big one as patients are living longer. Bone health is a big issue for us, maybe for you too. Smoking can be a big one depending on if we're doing fusions, insurance companies and surgeons. We don't like patients who are smoking or using nicotine. But other health comorbidities, heart issues, lung issues, things like that.
Yeah. Kind of the obvious stuff, but I mean, trying to knock out a lot of these questions while I have you here. It's just a very interesting conversation. Do you guys get together from a standpoint of as your group and go over case studies and review? Like, does that happen very often? Or do you guys kind of meet individually sometimes?
We're a very collegial group, so we'll run cases past one another and like ask, hey, what would you do for this one? What would you do for that one? There's always someone around you can grab and kind of, get an opinion. We do weekly meetings. You can always discuss cases there. We have an M&M where we kind of go through difficult cases every month. But we do talk about cases amongst us all the time. Yeah.
Awesome. Well, that's good to know.
Yeah.
I like some of the guys in your group. I've known them for a while. Dr. Herschel's great.
Good group.
Dr. Kress, those guys are all,
guys,
you guys all seem to mesh well together. But I was also I was curious in the standpoint of, longevity from a standpoint of, obviously everybody wants to do what they can do forever, but what's the longevity as a surgeon? I know a lot of different things can happen, but how long would you like to do this? How old are you now?
I am 43.
Yeah. How long would you like to do
I would like to go till probably about 70 and maybe run for president after that.
I think that's like a common answer now for a lot of people.
But no, I would, It is manual labor. A lot of what we do is like wearing the lead or hunched over in these cases with the tools, and you're sweating and you get done and your scrubs are drenched with sweat. So it is manual labor. Like, you leave at the end of the day and you're tired. So I would like to think I can do this for a long, long time, but there may come a time when I have to scale back what I do and how I do it and do different kinds of things. And I think there are lots of options for that. But I love what I do. I can't see doing anything else, and so hopefully I'll be able to go for quite a while.
Man, and
Yeah.
people that need you, they love the fact that you love what you do. So
Yeah.
there's no doubt about it. So from a standpoint of how people, get in touch with you, you're with the Orlando Health Neuroscience Institute, Dr. Avery Buchholz. Obviously, you can look him up that way, but is there any other?
Yeah, I do have a website, buchholzmd.com. My last name is Buchholz. I'm on the Orlando Health website. And I try and do a really good job about communicating with providers I work with, even patients. So most people have my cell phone. Patients, you have it. Most of the people I work with have it. So if anyone wants to reach out, happy to connect and just discuss that way.
And you are in clinic just evaluating patients how many days a week?
Yeah, so 2 days a week clinic, 2 days a week OR. 1 day is kind of whatever I need. If I need more clinic or more OR space, I have that option. I see patients here downtown at our Neuroscience Institute. I also go to Claremont, to our South Lake location, and I see patients and operate there as well.
Awesome.
Yeah.
And what do you like to do in your free time?
Play a lot of golf, try and work out when I can.
All right.
You know.
So what do you do for back maintenance, golf wise?
Yeah, so I'm not free of back pain either. And I thought about coming to see you also, but I try and do yoga, I do some Pilates, I try and get in the pool a little bit, but maintain core strength and don't do stupid things. Like, I've done CrossFit, and every time I do CrossFit, I tweak my back, so I'm trying to be careful of that.
You might have to talk to Dr. J, because he's kind of the guru when it comes to this CrossFit stuff.
Yeah.
I am not a fan of CrossFit at all.
Yeah.
As all my patients know that. Not that you can't do it, but I just see so many injuries.
You got to be
from
smart about it.
Yeah, absolutely. But well, that's awesome, man. I greatly appreciate you coming on the show today, and I hope everybody got a lot out of this. And it's not every day that you get to talk to a neurosurgeon. So once again, this is Dr. Dan Pavlik Jr. with the Let's Talk Health Forum, and we are sponsored by the Access Health and Wellness Association, and we'll see you next time.